Hi, everyone. Welcome to another edition of our Catheter National Thrombosis seminars. These are monthly seminars that are hosted live, where we discuss state-of-the-art VT and thrombosis lectures from Canadian and international speakers. The recordings are available on the CanVector website. And just a reminder that you can collect Section 1 CME via the Royal College. This is our planning committee. Dr. Wang is our chair. So today we have a very exciting talk from two of my colleagues. We're going to be discussing catheter-directed thrombectomy and ICU care of PE. And I'm very happy to be presenting our speakers. So first we have Dr. Lippis. Dr. Jed Lippis is an assistant professor in the departments of critical care and medicine at McGill. He's an attending at the Jewish General Hospital and the divisions of critical care and general internal medicine. He completed his training at McGill University, followed by a cardiac critical care fellowship at the Institut Universitaire de Cardiologie et de Pneumologie de Québec. And he completed additional fellowship training in echocardiography at the JGH. He's active in teaching postgraduate trainees in internal medicine and critical care medicine at McGill, with a particular focus on point-of-care ultrasound. He is currently the competency committee chair for the McGill Critical Care Residency Program. Dr. Lippis is a certified ECMO practitioner, and he is the medical director of the JGH ECMO program. His clinical and research interests include PE, obstetrical critical care, and mechanical circulatory support. Our second presenter is Dr. Ali Abwal Saoud. Dr. Abwal Saoud obtained his internal medicine and adult cardiology training at McGill. He later then completed training in interventional cardiology at the Montreal Heart Institute and adult congenital heart diseases at McGill University. He joined the JGH in 2016, and he became part of the pulmonary hypertension program and established the balloon pulmonary angioplasty program for the treatment of CTEPH after some training in Japan in 2018. The JGH BPA program is currently the largest and most active in Canada. He developed an interest in percutaneous and catheter-directed treatments for acute PE and became part of the JGH PERT team. He also co-directs as an active TAVI program at the JGH. So thank you both for agreeing to present today. These are the learning objectives for the talk. And please be reminded to send us our question. There is some time for questions at the end. You can enter them in the Q&A chat function, and I'll be moderating the question period at the end. So with that, Dr. Lippis, you can share your slides.
Okay, thank you to CanVector, and thank you, Camille, for the introduction and for the invitation to speak today. You can see my slides?
Yeah.
Okay. So as Dr. Simard said, I'll start off the talk today, and my colleague, Dr. Ali Abwal Saoud, will finish off the talk. We both have no disclosures to present. And so we're going to talk today about a little bit about how to classify and assess risk in acute PE. I want to go through some of the medical therapy and general ICU management for the high-risk acute PEs that we manage in the ICU. And then we're going to talk about the role of novel catheter-based reperfusion therapy. So I'll start off the talk with just a brief case. So this is a patient we saw about a year ago, who was a 70-year-old man known for hypertension, who was found by his son at home after losing contact with him for about 2 days. And he came in with a clear clinical stroke and a large left MCA lesion on CT here. So he was admitted to the neurology unit. And then 2 days after admission, there was a code blue called on the floor, as he had progressively decreased mental status, and he was found to be hypoxic at the time. Very soon, blood pressure wasn't really obtained, and he had a progressive cardiac arrest. This was preceded by an attempt for intubation. And then he had CPR for about 7 minutes and luckily achieved a return of spontaneous circulation at that time. And so he was put on the floor on very high dose vasopressors, and we quickly sort of escorted him down to the intensive care unit. And this isn't actually his echo, but this was representative of his kind of point of care ultrasound that we did, which shows this is a parasternal short axis view of the heart, where you can see here the septum is bulging with every contraction towards the left ventricle. And this is a very dilated, sick right ventricle. And then on very high dose support, we took him to CT to confirm the diagnosis. And this is a CT showing his saddle embolism here on the CT scan. So he remained in the ICU on very, very high dose vasopressors, on inotropes. He was on mechanical ventilation. And then we quickly had a multidisciplinary sort of bedside meeting to discuss what, if any, options there were to try to treat this gentleman. So I'll leave you with that to sort of ponder as we go through the rest of the talk. So as you're all very well aware, pulmonary embolism is a common entity, an annual incidence of about 1 in 1,000 persons, and it has a varying mortality depending really on the subtype of PE, whether it's a low risk, high risk. With the highest risk PEs have a roughly 40 to 50% mortality. The complications are numerous, largely related to bleeding due to treatment, but also recurrent VTE, chronic pulmonary hypertension, post-PE syndrome. So the classification of PE that we are using more and more is this one, which really assesses mortality and divides it into a low, intermediate, and high mortality risk. And based on these various parameters, including hemodynamic stability or instability, there are clinical parameters, largely based on the sort of the PESI score, the simplified PESI score, which includes kind of patient characteristics, including some physiologic variables. And then, importantly, the presence of right ventricular dysfunction, either on CT or on echo, as well as cardiac biomarkers. And so if we just go through this quickly, the lowest risk patients here are sort of often fairly easy to identify. They're hemodynamically stable. They have no high clinical characteristics that would pertain a higher risk, and they wouldn't have any sign of right ventricular dysfunction. Similarly, the high-risk groups are usually fairly easily identifiable as they lead off with hemodynamic instability. It doesn't really matter at this point how their clinical, what their clinical characteristics are, because they're by definition unstable, and they will all have some form of right ventricular dysfunction on imaging. The tricky ones are the intermediate groups, which are divided into the low and intermediate high group. So these are the ones who are hemodynamically stable, quote unquote stable, although they have clinical parameters that give them a higher score, and they have either one or two of the cardiac dysfunction based on imaging or biomarkers. Just looking at the PESI score quickly, which I'm sure you're aware, the original version and the simplified PESI, essentially giving you a point for age above 80, if you have underlying cancer, cardiorespiratory disease, and then some physiologic variables, including heart rate, blood pressure, and hypoxemia. And importantly, here you can see those with 0 points on the simplified PESI have a mortality rate of approximately 1% at 30 days, whereas if you score 1 or more, that risk goes up to 10%. And very important is the sort of the heart in all of this, the right ventricle. Even this is a data from a retrospective registry, but this is looking at patients who had normal blood pressures, and they're able to stratify them based on the presence or not of right ventricular dysfunction. So even in those patients who look kind of superficially the same with a normal blood pressure, the presence of right ventricular dysfunction increased their mortality from 4% to 8%. And a similar sort of pattern that we see, this is data from patients who were sent for catheter-based interventions, and so had a Swan-Ganz catheter in and able to obtain cardiac output measurements or cardiac index measurements. And they found that in patients who had really no difference in their PESI score or blood pressure, 40% of the patients actually had a cardiac index below 1.8, which is quite significant. So this just highlights the difficulty sometimes in truly recognizing the highest risk patients when they're hemodynamically stable, which triaging them is still quite a challenge. And the point of all this is to prevent this from happening, which is sort of the right ventricular death spiral that's often talked about, where the increase in right ventricular afterload, which results from the acute PE, causes a progressive cascade. And so as the right ventricle dilates, the wall tension of the right ventricle increases. This causes a cytokine storm, leading to further ischemia, further right ventricular demand, which then leads to progressive lower cardiac output, and then the cycle continues. And often this can be very dramatic and very fast. And so the goal here is to prevent, obviously, this from happening. So very briefly, just as a reminder in terms of right ventricular physiology, it's a little bit different from the left ventricle. The right ventricle is a thin-walled, compliant chamber, but really operates under low afterload in most cases. And the percent sort of increase in afterload quickly causes a rapid drop-off in your stroke volume. So it's very afterload sensitive. And importantly, preload, which is a tricky thing. We used to teach that preload, the RV was preload dependent, and we really had to volume load these patients. And to a certain extent, that is true. But we've learned over the last quite some time that if we overdo that and cause progressive stretch of their RV with excessive volume loading, we actually make the situation worse. And so it's a very tricky balance, managing hemodynamics in these patients, and particularly volume status. And in fact, there's been a couple sort of recent trials looking at this in terms of volume management of the acute PE patient. This is the DIPPER trial. So this was a randomized control trial taking patients with intermediate risk pulmonary embolism, and they had over 275 patients or so. And they randomized them to placebo versus furosemide 80 milligrams IV. And they had their primary endpoint was combination of a normalization of the physiologic variables on the PESI score, so heart rate, blood pressure, or O2 sat, but also urine output, or the absence of anuria or oliguria, which is, I have to say, a little bit of a sneaky endpoint, in that if you're giving someone who's maybe Lasix naive 80 milligrams of Lasix, there's a good chance your urine output's going to increase. But anyways, they performed this trial, and they had some safety endpoints and looking at, would this cause renal failure? Would they deteriorate and need vasopressors or arrest, or even need mechanical ventilation? And in the end, they found that there was really no change in their kind of cardiorespiratory parameters on the PESI score, although their endpoint was positive, but driven really by the urine output. So I'm not sure that's a very important endpoint, but it did show that you can still do this, not volume load them, in fact, diurese them a bit, and they weren't worse off for it. There was another trial sort of looking at the same question. So this was actually volume loading versus, this time it was furosemide 40 milligrams. And it was a smaller paper, but 30 patients in both groups. And they were looking at time to normalization of their troponin values as their primary endpoint. And they had some secondary endpoints, including BNP normalization and some echocardiography parameters looking at RV function, including what's called the TAPSE score or some tissue Doppler parameters. Their primary income wasn't really met. There was no real change in their tropes, although the BNP normalized in a faster time period. And you can see here the difference in diuresis. In the volume expansion group, they end up urinating 1,600, and the diuretic group had 5 liters that were diuresed. They did show some echo parameters that were significant in the diuretic group, in that they had a slight reduction in their pulmonary pressure, and their IVC diameter as a marker of your overall volume status was improved with the diuretic group. So sort of classically, historically, this is what we were faced with in terms of resuscitating the pulmonary embolism patient, is that we usually get presented a patient who is hypotensive and hypoxic. And our usual kind of go-to in the past has been a little bit of volume loading. Then we progress to vasopressors. And if we're forced to, we have to intubate these patients. Unfortunately, often these patients would then progress and have progressive RV failure and deteriorate further, which often ends up being more volume loading, and then it's coupled with a little bit of panic. And then, unfortunately, some of these patients worsen further and have cardiac arrest. And then we're extra stuck, where we're doing CPR. Maybe we're going to give some salvage thrombolytics and even more panic. So the sort of paradigm is shifting. And so one of the goals is to avoid that excessive volume loading. But I have to say that still remains a clinical challenge. At the bedside, we don't have that many interventions to help support it. We have inotropes and vasopressors, but we have to be very judicious in terms of the amount of volume loading we give. And the other issue is the intubation. So when we intubate these patients who are already quite tenuous in terms of their cardiac physiology, the active mechanical ventilation in terms of the positive pressure will often lead to a worsening of their right ventricular afterload. It can also alter their preload. And just the sedatives that we give on induction for mechanical ventilation is often enough to worsen their cardiac output. And so one of the major goals is to avoid intubating these patients if at all costs, which is often a very stressful kind of clinical situation. And then in the patients who are still deteriorating or at risk, then we have this, which is just a picture of an ECMO circuit. So I'll talk quite briefly about this option. So ECMO, or extracorporeal membrane oxygenation, just a little bit of a primer. The lingo is that there are sort of three sort of subtypes. There is veno-venous, or VV ECMO, which is used for really respiratory support. There is VA, or veno-arterial ECMO, which bypasses both lung and heart and is used for any form of cardiogenic shock. It's for cardiac support. And then the concept of ECMO CPR, or eCPR, which is simply veno-arterial ECMO, but installed during the act of performing CPR. And so what we do is we put a large cannula into the common femoral vein, usually, where we're then able, with a pump, we take the blood from the patient, we mix it through an oxygenator, CO2 is cleared, the blood is now oxygenated, and in the case of VV ECMO, we return the blood on the venous side, usually through the jugular vein, and therefore we have now well oxygenated blood entering the right side of the heart, and the patient's native heart then circulates the blood. So this really bypasses the lung and is used primarily for ARDS. Whereas VA ECMO, the same initial setup, you take blood from a catheter that's in the common femoral vein through the same pump, through the oxygenator, but you return it here on the arterial system, often in the femoral artery. And then this oxygenated blood is therefore circulated on the arterial system, bypassing the heart. It is resource intensive. There are many complications. The catheters are big. There's ischemic complications, bleeding complications. In the case of CPR, there's often anoxic brain complications, intracranial hemorrhage. So it's not, so we don't take it lightly. And obviously this is not performed at all centers. And so the logistics are an issue as well. But it is a little bit attractive for pulmonary embolism. And why that is because for VA ECMO, where you're taking blood from the venous side, bypassing the heart, it allows for complete cardiac support. And as you remove the blood from the right side, the RV is offloaded, decompressed, and you're able to maintain perfusion to the rest of the body. During an ECMO run, while you're on ECMO, this circuit is anticoagulated and the patient is anticoagulated. So you end up treating the pulmonary embolism at the same time. And because it's providing kind of cardiac and respiratory stability, if you want to go ahead and do more definitive therapy, you now have sort of a safety net, although a very invasive safety net, in order to do kind of definitive therapy, which we're going to talk about. And this is data from the ELSO database, which is like a large, the large international database that most centers subscribe to and upload all their data. And this just shows that there's been a dramatic increase over the last 10 years, specifically for ECMO use in pulmonary embolism. But it doesn't come, nothing is free in here. The mortality, when we look at ECMO use for PE from this database, shows that there's still quite a significant mortality. So in VA ECMO use, it's roughly 40% mortality, and in the case of eCPR, or the mortality jumps to almost 70%. At the same time, that's 30% survivals in the context of someone who's already arrested is actually pretty good. And the time on ECMO is around 3 to 5 days in these cases. The data out there is not super robust. This is a systematic review, but this is all, if you can see here, there are fairly small numbers. These are all retrospective cases, looking at the use versus no use of ECMO in pulmonary embolism. And really the sort of the data is not leaning one way or the other. But there is some kind of, this is a randomized controlled trial that we're trying to gain some insight from. This is the Prague out-of-hospital arrest study. This was not done for PEs. This was done for all out-of-hospital cardiac arrest, looking at randomizing them to an ECMO arm or standard CPR arm. So these patients were either, if they were randomized to the ECMO arm, they were immediately transported to an ECMO center and then placed on ECMO in the context of a refractory cardiac arrest, versus they were staying on scene and they did their usual standard of care, CPR and whatnot. But in this trial, which had almost 250 patients, they tried to look at the etiology of the arrest in all patients. And about 2% of the patients they were unable to sort of attach a etiology to. But in those that they did figure out, they had 24 patients, where almost 10% of these patients had a pulmonary embolism. And so if we look at these patients with pulmonary embolism, a couple of interesting things were found. One is that most of these PEs had non-shockable rhythms, which already is associated with worse outcomes. So 95% of the patients had non-shockable rhythms. And in fact, most of these patients arrested in front of the ambulance workers. But unfortunately, they had worse outcomes. So only 2 out of these 24 patients survived, 8%, versus in the rest of the study, they had about a 30% survivors. And so, I mean, it's hard to sort of, this is not randomizing PE patients to one arm or the other, but it's not that surprising when you have massive pulmonary embolism leading to a cardiac arrest. The active CPR in and of itself is often not very effective. And sometimes we get lucky, there's some autolysis and fragments occur and you can restore circulation. But if you're doing CPR with an obstruction to flow, the chances of a meaningful outcome are quite low. They did sort of spin this kind of paper saying that there was an increased successive organ donation in these PE patients, but obviously that's not the main goal. So once you're on ECMO, the question remains, well, then do you just sit on ECMO, give your anticoagulation, or do you opt for more directed therapy? So this is just looking at patients. This is a retrospective study looking at about 30 patients. In those patients that got some sort of fibrinolytic while on ECMO versus ECMO alone. And the ECMO alone patients actually did better. And this was looking at surgical embolectomy versus thrombolytics in patients supported with ECMO. This was a systematic review favoring surgical embolectomy in these patients, sort of suggesting again that thrombolysis while on ECMO maybe is not such a great idea. So when we're treating PE, obviously, as you know, the cornerstone really is anticoagulation. And then the question remains if we need acute reduction in clot burden with more definitive therapy, including systemic lysis, catheter lysis, catheter thrombectomy, or surgical thrombectomy. And really, this falls back to our risk assessment, where really the vast majority of our patients are going to do just fine with anticoagulation alone. And I think this still remains true for the trickier patients, including the intermediate high-risk patients. It's the sum of these subset of these intermediate high-risk patients we're still not totally sure what to do with. And for sure, the high-risk patients who have the highest mortality, we often need to reperfuse and reperfuse quickly. And what you're going to choose is really going to be depending on a lot of factors, including the logistics of what's available in your centers. And so it makes the decision making a little bit complicated, which I think highlights the need and the benefit of having a sort of a PERT type setup. If we just quickly look at thrombolysis, again, this is not new, but does remain a little bit controversial, and maybe even getting more controversial with more tools in the toolbox. So this is a systematic review, just looking at the potential benefit of thrombolysis. As you can see, this is going back from the 70s, but more recent data, sort of now about 10 years ago, the largest of the trial that drove some of this data is from the PETO trial, where they had 1,000 patients with intermediate risk PE, looking at the primary endpoint of death or hemodynamic deterioration with giving thrombolytics. And they found that there was indeed less deterioration with lysis. It wasn't really driven by death per se, but there's always a trade-off. And the trade-off here is more bleeding, not surprisingly, with 6 versus 1% extracranial bleeding. And importantly, they had a 2% intracranial bleeding rate versus a 0.2% in the placebo arm, which is the usual trend. More bleeding is the trade-off. But overall, the systematic review found that there still is a mortality benefit in the systemic lysis patients. But as you can see here, it's never good when your number needed to treat is much higher than your number needed to harm. And this is in the all-comers in this systematic review. Although when you look a little bit closer and they looked stratified by age, the mortality here still a benefit in those less than 65, but the major bleeding rate, at least for the number needed to harm, was much higher. And this is true also for the intermediate risk PEs, which they kind of classified this in their systematic review, where there still is an all-cause mortality benefit with lysis, but again, at a trade-off of bleeding. In terms of lytics, often now what comes up is what dose are we going to give? And so there have been a few papers looking at different dosing of lytics, although I still think there's a lot of work that needs to be done in terms of finding the right dose. But this is from it's now over 10 years ago. We're looking at 118 patients with high risk or large clot burden PEs on imaging, giving TPA 100 milligrams versus 50 milligrams, and showing at least in physiologic variables and echo parameters, pulmonary pressures, that the lower dose was as effective as the higher dose. And there's been a systematic review done looking at this, which essentially shows that there is less bleeding with the lower dose, with similar efficacy in terms of all-cause mortality and recurrent PEs. Importantly, with thrombolytics, there still remains, despite sort of dose adjusting, at least with systemic dosing, a significant rate of intracranial bleeding, and about 20 to 30% of patients have some form of contraindication to fibrinolytics. And so that remains a big clinical challenge in how to manage these patients. And so there's been a need for additional treatment options, which is why there's been a push to either use more novel-based therapies, including catheters or surgery, or just the use of ECMO in general. And with this, I'm going to pass over the microphone to my colleague, who will take us through the role of catheter-based therapy.
Thank you very much, Jet. That was great. I'll just share my screen. Let me know if you can see it. Okay.
Yeah.
So I'd like to also echo the same thanks for the nice introduction and for the invitation to this webinar. I have no financial disclosures, but I'd like to say that I'm not a pulmonologist or a thrombosis specialist. I'm just an interventional cardiologist. I spend a lot of time with the pulmonary vasculature or pulmonary arteries, and I use catheters, so you might sense that there is a bias. But I'm a big fan of multidisciplinary events like these, where like we share kind of experiences, and I learn a lot, and I enjoy it very much. So as a cardiologist, I'll also draw some from our experience with the myocardial infarctions, let's say, over a period of 2 decades, between 95 and 2015, MIs used to carry a very high risk of mortality, over 15%. However, with stents and improvement in medications, that's been reduced to less than 5%, both for ST elevation MI and non-ST elevation MI. And when I look at the mortality risk for PE, and this was really new to me, I was quite surprised by the mortality that's still there with at least intermediate high risk and or high risk, where it's about 5% for intermediate risk, and that even goes on until 3 months after you leave the hospital, which is up to over 10%. Of course, it's not all related to PE, but still, and a high-risk PE carries over or around 30% mortality, which is also like quite high with the current treatments that we have. So as I'll try not to repeat much of what Jed mentioned, but there are, as was mentioned before, limitations to anticoagulation alone. First of all, it does rely on autolysis. So if you do have increased RV afterload, you have to be comfortable that the RV or like know that the RV would be able to sustain this afterload for a long time. So if the RV wall tension increases or even dilates, as long as it functions well, probably anticoagulation on its own is going to be okay. However, once you start going to where RV contractility decreases, then maybe you should consider reducing clot burden, whether with lysis or something more mechanical. And certainly, if you start losing cardiac output and dropping pressure, then you should reduce clot burden as soon as possible and even consider support tests, like was mentioned with ECMO. Problems with limitations to thrombolysis now, as was mentioned, we know that thrombolysis works. Large burden clot reduces it. Afterload is reduced, but at what price? And again, the price of major bleeding and intracranial hemorrhage in many patients, unfortunately, is prohibitive. Not only that, but even literature shows us that even when we want to administer lytics in patients with high-risk PE, less of 30% of cases end up receiving lytics, probably for good reasons, but just tells you that you can't give it to anyone. And already at presentation, about 30% of patients have contraindications to lysis, so it's not even an option. And then mortality of high-risk PE still remains around 30%. So other limitations when patients come in. We know that thrombolysis plus ECMO is bad, as we saw earlier. Thrombolysis plus CPR, bad. And thrombolysis with surgical thrombectomy, bad. So you really have a small subset of patients that you can comfortably give. Not to mention that the clot consistency is very important as well. The more organized the clot, the less likely it will respond versus a fresh clot, which would probably respond much easier to full dose lytic, half dose lytic, or even locally. So if it's more organized, then you will end up with the side effects and without really any benefit or any response. And there's really, as far as I know, and as far as I can see in the literature, there's no real test to allow us to know how organized the thrombus is. Maybe if the patient tells you that it's been going on for weeks, or the pulmonary pressure is very high and there's mosaic patterns of the CT that may suggest more chronic thromboembolic pH, but still it's very difficult for us to assess. So what I gather from trials is that assessing PE risk is essential, much easier said than done. But you have to identify patients with pre-shock or silent shock. young patients tolerate hemodynamic compromise for a long time until they really decompensate. Guidelines tell you that for high-risk PE, you have to give thrombolytics and only consider catheters if there's a contraindication to lytics. And it also tells you that you need to reduce clot burden, and you have to do it quickly if the RV is failing without increasing the chance of bleeding. So what do we have in terms of like catheter-based therapies? There are two main categories. The pictures on the left are what we call catheter-directed lysis, which is delivering lytic, but locally into the pulmonary circulation, versus a mechanical removal of this clot, which is percutaneous mechanical thrombectomy, or sometimes it's called large bore mechanical thrombectomy, and we'll go over them briefly. These remain controversial, and they're not really mainstream, even though they're getting a lot of interest, particularly in the last 3 years, I would say, and especially in the interventional cardiology community. It's been being used more and more, and we're learning about it more and more. So why is it still controversial and not mainstream? One, there are no specific guideline recommendations to how you use it. Two, there's no large randomized data about it. And a lot of people would say that patients do well on anticoagulation alone, and it's probably true. And that the advanced therapies and taking patients to the IR or the cath lab and do something more invasive is considered too invasive, which may not be necessarily the case. This is a quick overview of what we have in terms of data. A few studies, really small volumes, but the ones with the blue dots are the randomized ones. So we have about 4 that have randomization, really not large numbers, but we'll see what they evaluate. I don't know if you have experience with catheter-directed lysis, but they're small catheters, really not very invasive. We go through the vein, we put in one catheter, 4 or 5 French, which are like big IVs, one on the left, one on the right. A lot of people argue also that why deliver it locally? I mean, regardless of where you give it in a vein, it will reach the pulmonary circulation. But if the rationale is, if you look at this as a ventilation perfusion scan, you have normal ventilation here, but clearly blood goes everywhere except where the clot is. So the areas that are perfused better have no clot. So your medication is less effective when you administer it systemically, and you will end up delivering potentially a higher dose with a more systemic effect rather than a local effect. So perhaps if you can deliver it locally within the clot, it will work. So what we usually do, we would keep it for about anywhere between 4 and 24 hours, administer kind of 1/8 to 1/4 of a TPA dose, and in the ICU usually. So instead of delivering it through just plastic, we had to make it a little bit more fancy. And this is what is called the ECOS catheter, where there's an ultrasound, it's an ultrasound-assisted lysis. And the concept is to break the fibrin and have a more effective thrombolytic effect. And it did show that it actually works in terms of RV/LV diameter and mean systolic pressure. But if you look at these are the randomized data. I don't want a busy slide, but if you look at the red areas, 23, 85, 59, 82, really not very big numbers. And then they all got the same thing, which is the RV to LV ratio reduction within 48 or 72 hours compared to anticoagulation alone, which was effective, but no significant mortality benefit, and maybe not even a bleeding benefit, except the canary, where it showed more bleeding with catheter-directed lysis versus more mortality with anticoagulation alone. And then there's one trial compared the ultrasound versus non-ultrasound and really did not show any significant difference. So instead of spending $200 on a plastic catheter versus $3,000, it's much better to, or I think in my opinion, until we get more evidence. Also, instead of going through all the data, there were relatively recent meta-analyses. This is one of them from October last year, looking at 15 studies, including 2 randomized controlled trials, comparing catheter-directed lysis versus anticoagulation alone. It encompassed about 10,000 or over 10,000 patients, and it did probably for the first or second time that there is really a potential mortality benefit when compared to anticoagulation alone. whether in hospital and 30-day, and it goes even further to 90 days and even 1 year. So telling you that perhaps removing the clot burden early on may have a long-lasting effect and improvement. If you look at the major bleeding and the minor bleeding, it did cross the line both. Maybe there was a trend, certainly more trend in minor bleeding, but that's not unexpected if you were going to access the veins and poke. So chances of minor bleeding is higher. Blood transfusions, for some reason, was more with anticoagulation, but just a trend also across the midline. No significant difference in intracranial hemorrhage, RV recovery, or length of stay. So certainly promising. Another meta-analysis even more from last year, looking at everything, anticoagulation versus systemic thrombolysis versus catheter-directed lysis. And if you look at mortality, there was no difference between anticoagulation and systemic thrombolysis, but when you use catheters, it was better than both systemic thrombolysis and catheter-directed therapy. Again, consistent with what we saw. Major bleeding, certainly lower in anticoagulation versus lysis, lower in catheter-directed versus lysis, but no significant difference between catheter-directed lysis and anticoagulation. Intracranial hemorrhage, both better than systemic thrombolysis, yet catheters versus anticoagulation, not a significant difference. And minor bleeding, maybe a little bit more with catheter-directed lysis. So this is I'll try to go a little bit faster. This is our first case where we tried to do it on this gentleman, 68, who came in after a fall subdural hematoma for about a month, and then presented to ER in shock, cardiac arrest, CPR, got ROSC on high-dose pressors. And this is the pulmonary angiogram. We ended up putting two small catheters and used catheter-directed lysis. 24 hours later, he actually decompensated. So to come again for scan. But interestingly, his PAs were dramatically better. I was very surprised by the amount of clot burden that was reduced. But he had a substernal hematoma that was compressing the right ventricle due to his CPR, and that's why he ended up going to, for cardiac surgery. For evacuation, there was no RV injury. He actually did well, recovered completely, and left the hospital weeks later. So that's what we have in catheter-directed lysis, and it's quite promising, and we think it maybe potentially there was a mortality benefit. How about mechanical removal? The two main ones that we have that have a little bit of evidence behind them are what we call the Penumbra, Indigo, smaller, lower profile catheters. They're introducing a new one, or the large bore catheter, 24 French, large in-RV flow retriever. Again, busy slide, but this is their trial that shows feasibility, where there was really one patient out of 119 that died, and 2 had major bleeding. There was pulmonary vascular injury that led to the death, but otherwise, there was like a median stay of 1 day in the intensive care, relatively efficient and relatively low risk with significant reduction in RV to LV ratio. The Inari, larger patients, this is the registry of 800 patients that included even 8% high risk. None of the trials for catheter-based therapies included high risk. This one had about 8%. 32% had had thrombolytic contraindications, and 26% had low cardiac index. And then if you look at the all-cause mortality within the 48 hours, it was 0.3% with 1.8% major adverse events, and all-cause mortality was less than 1% within the first 30 days. A follow-up more recent, I think that was also October last year, showed that, again, patients continue, even though it was less than 1%, it was 4.6% 6 months later. A newer, probably more exciting trial, for the first time, a high-risk trial, non-randomized, but prospective trial that took patients with massive PE or high-risk PE and either administered a flow retriever or just regular treatment with whatever they wanted to do. So they actually gave the options for the per team to choose whatever strategy they want to use. But if their choice was first-line flow retriever, then they would go into the flow retrieval arm. Otherwise, it would go into the context arm. And they had something that what's called a prior treatment arm where it was treated, and then they wanted to switch a FlowTriever, but this was only one patient. So let's see what happened. Again, this is not randomized, about 100 and like over 100 patients, 110 patients. So they did a meta-analysis, and based on that, designed their trials. And this is the performance goal is what they thought they would see in terms of results. So from a major bleeding standpoint, it was 11.3 with the FlowTriever, very consistent with a performance goal, but much higher in the context arm, included many things. Clinical deterioration, 15%, 15% as expected, but then 20% or over 20% in the context arm. Bailout, the use of another strategy, was about 3.8% in the FlowTriever arm, 30%, which was the performance goal, and it was 26% in the context arm. But then we come to mortality. So again, this is how you would treat any high-risk patient, 29.5%, very consistent with the 30%, or what they thought was 28.5%. But this is the mortality in the FlowTriever arm, which was quite impressive. Of course, there's a big selection bias, but it also tells us that if we are selecting patients properly, we are going to be able to reduce the mortality of high-risk PEs, hopefully. And then finally, it's just in terms of like primary endpoints, it was much lower than what performance goal was and much higher in the actual treatment context arm. Again, just that these are the same trials, but just to show you that these are the randomized trials or the trials that are ongoing, which are a lot in comparing the both mechanical thrombectomies to the catheter-directed lysis and various strategies. So we will have a lot of information on how best we treat those patients. So we'll come back to our case. Again, high pressure, very dire situation. We did a rapid FaceTime mini-PERT meeting. There was an absolute contraindication to thrombolysis due to the recent large CVA. Patient was on maximum support, and we decided that we're going to attempt mechanical thrombectomy with the Inari FlowTriever. So we go through the femoral vein. This is a pigtail where we would do our pulmonary angiogram. We would put a stiff wire in and put our 24 French and start aspirating. So this is the pulmonary angiogram. I think it's very clear where the saddle emboli are. And this is what we were able to retrieve. So in someone who's really, really in a bad shape, and it was really gratifying to see. But does that really translate into clinical improvement or not? I mean, you would hope that after doing that and seeing this on the pulmonary angiogram with like impressive improvement in perfusion, that the hemodynamics would improve. And sure enough, his pulmonary pressure, if you can see here, went from 61 to 30 and the mean from 35 to 22. But again, in the context of a stroke, we were not sure how he was going to do, and he was intubated and 7 minutes of CPR, ROSC, but he ended up leaving the hospital 2 months later and is currently actively being followed in the clinic. Our first case of mechanical thrombectomy also was in a more stable patient, but also achieved a significant improvement in pulmonary pressures. And this is just our third. So from each procedure, you learn quite quickly. And this is just to show you the log of the procedure and how efficient it could be. So from the time the patient is put on the table, at 12:12 p.m., we start local anesthesia. Within 6 minutes, we're able to get all our hemodynamics. Minute 7, pulmonary angiogram is done. And within another 7 minutes, our thrombectomy starts. And then, of course, we went in everywhere to try to clear up the lungs, but the procedure took about an hour, and the patient did really well. So in summary, for catheter-based therapies, these therapies are definitely here to stay. Faster clot removal and faster RV recovery is easily achieved and prevents RV failure, which is usually the cause of death. And there's potential data that it will prevent chronic thromboembolic PH, just because statistically speaking, it's about 3 to 4%. And in data that we have, it was around 1%. But of course, it's not risk-free. Large bore catheters, punctures, we have to be very careful. We go through the heart, the tricuspid valve. DVTs, clots in transit. It's not always easy, but careful patient selection will lead to better outcome. And we as a team are learning as we go as well with how to approach these patients. So I'll give it back to Jed just to conclude, and we'll take any questions.
Yeah, so I think we have to remember that the high risk PEs still have this very high mortality, and we often need to act quite quickly. And the intermediate high risk still have a significant mortality. It's not the 30%, 40%, but still 5% is one of the higher sort of diagnostic etiologies that have a very high mortality. And trying to risk stratify them properly is still a key thing with biomarkers, RV assessment, and so on. Go next slide. And so really the conclusion overall is still anticoagulation remains the cornerstone. We can't forget that. But we still have to consider that the high risk patient and some of the intermediate high risk still do need urgent reperfusion therapy. In terms of lysis, probably in terms of dosing, less is more, but really getting that right is still very controversial, and the data is still lacking. I think catheter embolectomy is likely to play a very prominent role. And remember, in terms of ECMO, although they are highly specialized, I think it can still be used to support patients. But from that randomized trial, I think best is prior to death. Rescuing these patients with ECPR is really not the strategy you want to go with. You want to support them before bad things happen. And I think with that, thank you very much to CanVector, to Ali for presenting with me, and to the whole team.
I'd just like to mention that, I think the best thing about such a program is just having the multidisciplinary approach. And we're really proud of how our, team is functioning in terms of it's very easy for us to talk to each other. And really, I think patient care is improved a lot by, having different minds coming together. So there are too many to put pictures of. These are our cath lab team down there, and then multiple specialists, as you may know. And I'll leave it for questions.
Thank you very much, Dr. Lepis, Dr. Abouassaoud, for a great presentation. Ali, I noticed you're not yourself on this last slide, and your picture is not there, but you're very much part of the team. So the floor is now open for questions, and I'll start right away with a question in the chat. So feel free to enter your questions in the Q&A. So first question, do you recommend patients be treated with a split dose of low molecular weight while being assessed by PERT before deciding on whether advanced treatment is needed? Great question. Dr. Lepis,
I think Ali can speak to this as well, but in terms of in terms of catheter intervention, I think the data also says really the presence of having anticoagulation, full dose anticoagulation on board does not limit proceeding with catheter-based interventions. The same is true for if we have to crash onto ECMO, being fully anticoagulated is not a problem. So not sure you need to split the dose necessarily, but I think the more important thing here is just make sure they are anticoagulated, and sometimes that reverts to the kind of low molecular weight IV heparin debate. I'm always a little bit fearful of IV heparin underdosing, but you guys are probably more able to answer that question than I am. But you get full dose doesn't impact the rest of the interventions.
I'll mention, I'm used to puncturing veins and arteries, and definitely go full dose heparin. It's a big difference, low molecular weight heparin or whatever strategy you want to choose. Don't worry about doing something more invasive. Lytics, on the other hand, here is where it becomes a little bit difficult. You want to go on ECMO, it's a problem. So really, you have to be sure. And sometimes you're never sure, but from puncturing a vein, it really is very easy. If we need to put them on ECMO with full dose heparin, low molecular weight heparin, it's also relatively easy if we do it carefully and under ultrasound guidance we usually use. It's just the oozing that happens with the lytics is what makes it more difficult to control. But these, I would talk about catheter-based stuff. is really non-invasive. The pressure is very low. The veins are very forgiving. And we can really, like, even if there's a bleed with like a pinky, you can really stop it. The RA pressure, the venous pressure is like 10, 15 millimeter mercury. So I wouldn't worry, and I wouldn't hesitate.
Great. So no delay of anticoagulation while we decide on these advanced therapies. That's helpful. There's no other question in the chat, but maybe I have a question as someone who's not an intensive care physician. Who, if you could maybe, Dr. Lippis, elaborate on who the patients are that benefit from ECMO in the event of a pulmonary embolism, and what goes into making that decision?
So it is a challenging question to answer because we don't have that much guideline, and some of it is kind of just feeling. But I think there are patients who, so the highest risk patients really are the ones who you're going to be targeting. I think if you take the intermediate high risk patients who are hemodynamically stable, putting these patients on ECMO is really unnecessary, and I'm not so sure that's a worthwhile strategy. The highest risk patients who are either sort of deteriorating in front of your eyes, those are probably the easiest patients to identify and catch, despite being on, vasopressors, because there are sort of two categories of high-risk patients. They all, from a research point of view, they all lump into hemodynamically unstable, but there are, the hemodynamically, there's like the stable, unstable patients. So who are stuck on low-dose vasopressors, but who are otherwise okay. They're on 5 mics Levophed. And that's a very different patient than the patient who is kind of changing in front of you. And so for those patients who are really, really changing in front of you, those are the ones who we really want to act fast and put them on, because as I showed, if they progress and they have a cardiac arrest, everything has changed. Like your outcomes change, your ability to do things successfully change, the risks of cannulation changes, that you really want to avoid ECPR as a strategy. So you have to try to select the most, the unstable patients are the true target. The other category, though, is the patients who are, you have more time, they might be unstable, but they're on low-dose pressors. But you are still worried due to their clot burden, or maybe they have clot in transit, or there's this DVT associated that you're aware of, and now you want to go to the cath lab and do some other intervention. It's very nice to have them supported while you then go to more definitive therapy. So if you take someone on ECMO and then who is very unstable and you bring them to the cath lab, that provides you with quite a nice safety net to then be able to do interventions. So that's another kind of category of patients. Yeah, but it still is a challenge. I have to say it is a bedside challenge, and you have to figure out what you're able to deliver to the patient, kind of in your center, depending on like the speed. So sometimes you make the decision based on, you're forced to say, okay, we need to reperfuse this patient in the next 10 minutes. What are we able to deliver to this patient within 10 minutes? It might be surgery, it might be ECMO, it might be lysis. So you have to be able to figure that out as a group.
Thank you. That's really helpful. Did you want to say something? Sorry, Ali.
No, I just wanted to, I see another question there.
Yeah, I was going to alert you to that question. Specifically for you, do you know, so from Landeng, who says, thank you for the great presentation. Do you notice more hemodynamic instability with the NRE 24 French catheter when you're entering the PA?
So I think that's an excellent question. And I'm not sure why you asked it exactly, but when the RV is very dilated and the heart is globular, perhaps putting something that's rigid may cause this hemodynamic compromise. We see it with putting pulmonary valves, let's say, or doing like congenital pulmonary interventions, but it's usually because of tenting of that tricuspid valve, and then all of a sudden you lose forward flow. But it is somewhat unclear. This particular case was the only case that all of a sudden, even though as the clot is coming out, we go in and out, the clot came out, great pressure, but then all of a sudden we had this hemodynamic kind of compromise, which was like, didn't make sense and was transient. And as I'm hearing more and more about, are other cases, I can't recall that happened. It's relatively flexible and it's nice. But certainly people had this acute drop in pressure. It didn't happen though as we enter. It happened like as we're, manipulating. One of the issues that we face with the Inari, even though it's a 24 French, is that you have this what we call a lollipop effect, where the clot gets stuck at the tip of the catheter and doesn't get sucked in completely. The reason you saw the video where that big clot came in, it didn't come into the syringe. It stayed in the catheter. So we had to pull the catheter out, flush it, and that's where the clot came out. And when we do this multiple times, that's what I noticed, that maybe it's part of the problem, but certainly it is a risk. We haven't really dealt with that. I mean, it didn't really affect the outcomes in our cases, but it's something that's been clearly mentioned.
Great, thank you. So we might be gaining more experience with this as time goes by. So it's 101, but we'll go through one last question maybe for you, Ali, regarding CDT, which dose of lytic therapy and how many hours of infusion?
Yeah, that actually I'll defer to Jed, because I put in the catheter and let him decide. But go ahead.
Yeah, I mean, so it's hard. So if you look, there's a few nice slides out there, regarding this, but the early trials with CDT used, I think, 24 milligrams and 12 to 24 hours of intervention. And now the game seems to be the least amount of hours and the smallest dose. So there is data using it for 4 hours or 8 hours. So honestly, I have to tell you, our protocol here, which is based loosely on what's around in terms of literature, is usually a milligram or 2 milligram bolus and then a milligram per hour for somewhere in the 8 to 12 hours. But that is based on some copying the other protocols from the trials. But it seems to be that, we're using less and less.
Great. Okay.
Sorry, go. Yeah.
Sorry, you can finish your... No, okay. Well, there's one last interesting question, probably from someone who has experience with this. So I'll ask you if you have time. From Benoit Cote, great presentation. We have done 15 selected cases in the last year with great success. I now tend to favor FlowTriever before lytic, even in high-risk patients that need pressure. If I think we have time, do you feel the same way, that we're going to lytic less and go to the lab more?
That question's for me, most definitely.
Yeah.
I think as we look, the technology is just getting better and better. We're knowing when to use and when not to use. I think if you're at a level where you want to start lytic, unless you're like the patient is dying there and you have to give it, probably you should stop and then consider other things, just based on what I see. Young patients, on the other hand, they have a less risk of bleeding. So maybe the half dose while you're, it might be okay. We get a lot of calls from other hospitals as well. And with these young patients, by the time you get them in and assess and all that, just try to give it. Above 65 or relative contraindications, definitely there is a lot that's available and coming, whether it's for the central clot that's saddle or for more segmental, subsegmental with a large burden. You can really be selective. So I think slowly, and I'm kind of confident that the current randomized trials would show significant benefit over lysis, at least, if not better than even catheter-directed therapy. It may, based on our experience with catheter-directed lysis per se, I think I was very impressed by it, and I think it still will have a role if you don't want to necessarily remove it. But I favor FlowTriever too. I haven't tried the Penumbra Lightning, but for the point that earlier, for the instability with the 24 French, perhaps going with a more flexible catheter in patients with high pressure, really like hemodynamic compromise, might be better. But from what I see, it comes as fragments rather than a big clots, and that's why I would go FlowTriever regardless and then deal with it.
Perfect. So more action in a cath lab is predicted, I think, is the message.
Probably.
So thank you both so much for a great presentation. Thank you for your time today. And thank you to the audience. The webinar is recorded and on the website, and please stay tuned for our next seminar, which will take place in April. And have a nice afternoon, everyone.